Okay, just a couple more moments and then we will start at 12 o'clock. Got a packed agenda to get through this afternoon, so do want to kick off on time. So, afternoon, everybody. There are still people joining, but we will make a start. My name is Jane Rooney. I lead the Elective Hub Accreditation Programme across the country. I'm going to be facilitating today. We've got some great speakers for the masterclass today, which is on shared decision making and consent. As it says on the screen, if you could please keep your camera turned off during the session, it just makes it easier for the speakers when they're talking. Please turn your phone on to silent and mute your microphone. Due to the number of people that we've got on the call today, please, if you have any questions, drop them into the chat. There will be a chance to put your hand up and ask questions after the speakers have spoken, and then again at the end we will have a question and answer session. Just so you're aware, the session is being recorded and the slides from the speakers will be shared after the recording. Any documentation or slides or the recording of the session will be put onto the Futures website so that you can download those if you would like to share them or watch any of them again. So, without further ado, I'm going to go straight into this. You can see the agenda here in front of you now. We are kicking off with Professor Alf Collins, who's Clinical Director of the Personalised Care Group at NHS England. Delighted to have you with us this afternoon, actually, not this morning, this afternoon, Alf. So, yeah, without further ado, let's go across to Alf.
Fantastic. Thank you very, very much. I will see if I can share my slides. Can you see that, Jane?
Yeah, we can see those.
And I'm going on to slide view. Good afternoon, everyone. Welcome from a very wet and windy Somerset. I don't know where you are, but it's a pretty rainy day here in the southwest. I'm going to spend a few minutes talking with you about shared decision making and consent. I'm an ex-anaesthetist and was very used to assessing people in the perioperative period. So I've got kind of a professional background in all of this stuff, but for the last 20 odd years, I've been researching shared decision making, and now I'm National Clinical Director for Personalised Care, including shared decision making. A few slides and then a little bit of time for questions. There are really three routes to shared. Some people talk of informed or supported decision making. One of the routes is it's an ethical principle, support for informed patient autonomy. The second comes from the decision-making consent arena, actually from President Jimmy Carter in the States. That's where the words shared decision-making first came from in the late 70s. But also evidence-based medicine, another route of shared decision-making. Because what shared decision-making is evidence-based healthcare tailored to individuals. It's a coming together of best available evidence, but of course that evidence is based on populations of people, clinical expertise and individual patient characteristics and references. So that's what evidence-based medicine is. So shared decision-making is part of evidence-based medicine. It's a methodical application of population-based evidence to individual clinical characteristics and personal preferences, leading to improved decision quality and high-value care. So it's a coming together of what clinicians know about the options, the benefits, the harms, the uncertainties and the consequences available at any particular time in someone's journey. Alongside what patients bring is their circumstances, their values and their preferences. And if we explicitly bring that together in what's now called a What Matters to You conversation, we can ensure that we make a decision together that accords with both evidence and personal preferences, a high quality decision. As I said, it comes, one of the original roots comes from a US Commission on Decision Making and Consent in the late 70s. But we have, in this country, the General Medical Council has done a lot of work on decision-making and consent, really pursuant on the Montgomery case from 2015. I'll talk a little bit more about the Montgomery case a little bit later on. 3 years ago, there was new guidance came out for the GNC, or updated guidance, should I say. The patient should be the primary decision maker, number one. Decision-making and consent is a process and not an event. Patients should be given time, information, and support. Options, benefits, harms, preferences, and unknowns should be discussed, including the option of doing nothing. We should assume capacity, but for those who lack capacity, we should work with advocates. And of course, as always, we should be aware of safeguarding and Mental Health Act principles. But this shift towards patient as primary decision maker is, I think, absolutely pivotal. But let's be clear, shared decision making and consent are a process, but they're a process where there are different emphases given in those conversations. Shared decision making should be a series of unbiased conversations about the benefits and risks of all reasonable options, including doing nothing. Alongside this thing, preference solicitation, what matters for you? Consent, which comes towards the end or at the end of the decision-making process, is more often an event. And frankly, by the time patients come to a consent conversation, they should already know the benefits and risks of the procedure under consideration, and they should already know about the benefits and harms of alternatives. Consent is a more focused conversation. It's not an unbiased conversation about more available options. It's a more focused conversation, primarily about the risks, but also the benefits of the procedure under question, and a slightly more cursory conversation about the alternatives alongside preference solicitation, again, what matters to you. But really, it's the culmination of a process. And consent, there is a medical legal angle to it, really, as I say, drawing on the Montgomery tort law shift in 2015, which focused on materiality. And materiality is the significant impact on an individual should a known risk materialise. And Lords Kerr and Reid said, the test of materiality is whether in the circumstances of the particular case, a reasonable person in the patient's position is likely to attach significance to the risk. Or the doctor should be reasonably aware that this particular patient was attached significance to it. So this is just really, really important. It's what a reasonable patient will want to know, as well as what this particular patient will want to know. So unless we're asking them about the outcomes that matter to them, frankly, we are failing when it comes to Montgomery. And asking patients what matters to them when there's a consent form sitting in front of them, sometimes on the day of surgery, is probably not the best way of going about informed decision making and consent. There's a very, very significant safety angle to all of this. The Patterson inquiry, for those of you who don't know the Patterson inquiry, do look it up. I represented NHS England when it came to decision making and consent within the response to Patterson. An incredibly harrowing process, I have to say. And secondly, First Do No Harm, the report by Baroness Cumberledge, which was a little earlier than Patterson, but they're saying the same thing. They're saying the same group of things, which is that we should be ensuring that patients are the decision makers insofar as they want to be. We should be ensuring that they have knowledge of all the benefits and harms of all reasonable alternatives other than doing nothing. And we should make sure that they're supported to make a decision that's right for them and given time to do so. The fact is, though, we don't do it as well as we perhaps could. And these are the data from NHS Resolution. Down the left-hand side, years from 2011 to 12 to 2021-22. And just to look down the right-hand column, and you can see just how much claims are costing in this country. And of course, this is just the tip of the iceberg. This is just the tip of the iceberg. So £80 million last year and rising. So This is a busy slide, but I just want to take you through it. Gold standard, which we really should be aiming for, is that patients are aware of all reasonable options in primary and community services. Let's think about someone with, I don't know, knee pain. Then they should be sharing decisions quite early on in the course of their knee pain about reasonable evidence-based approaches, getting a little fitter, simple analgesia, maybe seeing a physio, maybe joining a walking group. If after time that's not as helpful as they would like, or things are progressing, then it may be that they share a decision about proceeding to see a secondary care clinician, where again they start to think in a shared decision-making conversation or a series of shared decision-making conversation about secondary care-based treatments. I would say then, at the end of that, they say, actually, do you know what? I really do want to proceed with the knee replacement. I know about the alternatives. I know about the benefits and harms of knee replacement. That should then be a provisional decision if patients in particular have a moderate to high perioperative risk. So it shouldn't be a confirmed decision to proceed until they've had a pre-op assessment, after which it may well be the case that they proceed to sign a consent form. So you can see there's a big process sitting behind, a long shared decision-making process sitting behind the event of shared decision-making. I put down there at the bottom, the event of consent. I put down at the bottom there, where should pre-op assessment sit? I think it's just, at the moment, we're assessing people when they've already kind of decided to proceed with surgery. I think it should be provisional decision, dependent on their perioperative risk. And it could be the case that as a result of a perioperative risk, they say, actually, do you know what? I'm going to revisit some of those other treatment strategies that I've perhaps tried in the past or maybe didn't try, because I think it's just too risky for me, actually. So maybe pre-op assessment should sit further down the pathway. And I know that it's happening in a number of trusts and a number of areas right now. Perhaps many of you on this call are already doing that. I'm going to be started to come to an end in the next few minutes. Shared decision making is relatively straightforward. We need to make sure that patients are prepared. They have a decision support tool if one's available. They're prompted to ask questions. We need to make sure that teams are trained in motivation interviewing and in eliciting preferences, what matters to you, and in risk communication. And we need to make sure that the system's supported, the workflows and the organisations support decision-making and consent. What we've done in NHS England to make this easier is we've produced a bunch of decision support tools. Chloe's going to talk about them in a few minutes. And we're in the process of getting those decision support tools and indeed digital pre-op assessment on the NHS app. In terms of training, we've set in place something called the Personalised Care Institute, which is a training organisation, and I'll put a slide up about that in a moment. And what we're trying to do, it's harder than I'd like, is get decision support tools into clinical systems. But there's the Personalised Care Institute. It's got simple little training avatars. Another one came online yesterday. 10-15 minutes of fun learning. Do think, if you've not undertaken Personalised Care Institute training in shared decision making, of having a look. Chloe's going to talk more about the decision support tools, but I just want to tell you a bit of an outline about them. We've got 30, by March next year, we'll have 30 decision support tools focused on high volume elective care pathways. They improve patient engagement and satisfaction. They improve decision quality. They reduce decision regret. 1 in 7 patients regret having surgery post-op. They reduce litigation by about 80%. They improve informational continuity across pathways of care. They improve adherence to evidence-based practice, and they align practice with GMC guidance. So, you know, what's not to like about using them? I think what's really important about them is that they tell patients they have options. Many patients don't even know they have options. They explain what those options are, including doing nothing and things you can do for yourself. But really importantly, they ask patients about their preferences, what's important to them. The evidence is actually pretty clear. It's only in about 25% of clinical scenarios or clinical conversations that we actually do have a what matters to you conversation. So, you know, these decision support tools do it for us. And then this part 4 is designed to be used in the consultation, because clinicians are pretty poor at understanding benefits and harms and pretty poor at communicating them as well. Now he's going to talk a bit more about them after me. I hope I've impressed upon you that this is a process. This is an end-to-end process, decision-making and consent, starting with a series of unbiased conversations about all available options and finishing with an event consent where the particular option is considered in more detail. But I think there should be absolutely no surprises by the time it comes to a consent conversation. Patients should have known about the benefits and harms by the time they get to it. Jane, that's all I wanted to say. Over to you.
Thank you. Really, really useful. Lots of fantastic information in there. So we've got some questions starting to come in. Before we come to those, Alf, I've got a question which I'm asked an awful lot when we're out doing accreditation visits, and I know is close to a lot of people's hearts when they're thinking about shared decision making. It's very difficult to find the time to do it, is what consultants say to me an awful lot. The nurses in pre-assessment say the same thing. The anaesthetists, it's just too difficult. There is no time. So what would your response be to that question?
I'm sympathetic. However, I would say this is an ethical, professional, and legal standard, right? This is an ethical, professional, and legal standard. The evidence is actually really quite clear that if we are trained, if we orient the system to make sure that patients get decision support tools beforehand, are prompted to ask 3 questions, it does not take longer. It does not take longer. But we have to orient the system to do it well.
Yeah, great answer. Thank you. Elizabeth from Royal Devon Hospital is asking, would you say that using your cataract decision support tool must be part of every choice conversation with patients deciding to be referred for surgery? Hi, Elizabeth.
Absolutely.
Sorry, I've just read your question.
Absolutely, yes. You know, these decision support tools in Australia, for instance, they started to become mandatory. We're not there yet in this country, but the evidence is really clear that both patients and clinicians overestimate the benefits of surgical procedures and underestimate the harms. Added into that decision regret, I wish I hadn't had surgery, occurs in 1 in 7 patients, and that the use of these tools tends to lead to a reduction in a desire to proceed to surgery. My sense is that they're ethically really, really, really important. Added into that, my wife's 65, was told by her optometrist, do you know what? You've got a cataract. You need to have surgery. And I said to her, hang on a bit, have a look at one of these decision support tools. She's decided not to go ahead. She didn't even know about the things she could do for herself. She now does, having read the decision support tool.
Elizabeth, have you got a response to that?
Yeah, no, I'd love to, I don't want to sort of kibosh this meeting. I'd love to perhaps talk, I'm only down the county from you, Alf. I'd love to be able to talk about that, because I think that's absolutely the experience of every other patient referred for cataract surgery, and they don't have the decision support tool. So I'd love to be able to talk to you about how we might take that forward, because I think it's really, really important.
That's really good, Elizabeth. I'll put my email address in the chat.
Thank you.
Thank you, Elizabeth. We've got a question here from Naveed, who's asking, what should we do when GIRFT or NHS recommendations challenge the preservation for patient autonomy, such as don't offer an injection as an option when it is a reasonable option? How do we carry out the SDM conversation when the focus is on not seeing the patient for follow-up or changing clinic templates that reduce the time of consultation?
We just go back to that first question. Sorry, Jane. Was the question about whether to offer all reasonable treatment strategies?
Yeah, I'm not clear. Naveed, do you want to put your camera on and ask the question? That's probably easiest.
Sorry, I want to train journey at the moment.
Good on you, Naveed. Good to see you, mate.
So, thank you. So, I mean, obviously, SDM is just central to providing the right thing to the patient. One of the concerns we come across is that guidances that are based on evidence suggesting don't offer, for example, in back pain or in certain conditions, an injection, repeated injections. But in the medical profession, that would be a reasonable option versus doing nothing or having major spinal surgery. So when you're having the SDM discussion, that would be a reasonable treatment option. And you do, or you should discuss that with the patient. But as part of a lot of the guidance, it may conflict that. What do you do in that scenario? Because your responsibility is to the patient. What advice would you give in that scenario?
So shared decision making isn't doing everything the patient wants, right? It's an adult conversation. We are under no obligation as clinicians to offer treatments that we do not feel are reasonable. It's a whole other kind of minefield conversation, this, but it's actually just been tested in law, that particular principle. Now, what do I mean by reasonable? Well, there's no evidence to support it. Your professional opinion is it won't work in this particular patient. There are a series of reasons for that, but we are under no professional obligation to offer treatments that we do not believe are reasonable. So, what I would say is that, frankly, I think most of us should stick to the guidance and not offer treatments that are out with guidance. That's a particular view of mine, but I come from the evidence-based medicine tradition. I hope that helps.
Thank you, Naveed. I think we've lost him. He's gone in a tunnel. We've got quite a few people in the chat saying if this is followed properly, it does actually save time, which is very reassuring. Got time for one more quick question, Alf. Interesting one, this. Given the volume of clinical activity paid for by the NHS in the private sector, is it about time the NHS mandated the use of these tools in these settings where fee-for-service might distort activity levels?
Yeah, it's a great question. As I say, that they're starting to do it in Australia. The problem with you start to think it through, and what we want to do is to support clinicians to know and understand this is best possible practice. This is ethically, professionally, legally best practice. And what we want to do is for clinicians to take them up out of their own volition and patients to be asking for them. That said, it's not off the table, right? That's what I'd say. Mandation is not off the table.
Lovely, that's great. We have got other questions in the chat. Those we will put some FAQs out about after the masterclass today. Alf, we've run out of time, I'm afraid. Thank you so much for joining us today. And I'm sure you've all found that really helpful to listen to. Brilliant. Thank you very much, Alf.
Thank you.
So we're going to move on to the second speaker. Afternoon, Chloe. Dr. Chloe Stewart's the National Clinical Advisor in Personalised Care and Musculoskeletal Conditions, and she's going to talk to you about shared decision-making support tools. Chloe.
Thank you, Jane. Yes, I'm Chloe. I work really closely with Alf at NHS England within the personalised care group. And as Alf said, I'm going to talk to you now about the decision support tools that we have created. I'm hoping that someone is going to share my slides. Brilliant. Almost up, I think. Can't see them yet, Jermaine. Jane, can you see that?
No, they haven't come through yet. Looks like they're coming. Bear with us, everybody.
I'll share them instead. Hang on.
Thanks, Sophie. Okay, brilliant.
You can see those.
Thank you. So one of our roles in the personalised care team at NHS England is to support clinicians and patients to do shared decision making. And that's why we've embarked a couple of years ago now on a project to produce decision support tools, which is what I'm going to talk to you about today. I'm hoping that most of you know about these tools and are in fact using them. Next slide, please. So as I said, we started to produce these about 18 months to 2 years ago now, and we started the production working alongside the Winton Centre for Risk Communication, which is based out of the University of Cambridge. And more recently, we've been working with NICE to produce the tools. And as Alf has said, there will be 30 in total by the end of March next year. The one you can see on the right here is the tool for knee osteoarthritis. So it gives you a bit of an idea of what the tools look like. I know Alf has just stolen my thunder and shown a few of them as well, but we're going to just go through the tools a little bit today. Next slide, please. So why are we doing this? How do decision support tools help? And you might also know decision support tools as patient decision aids. So we know that decision support tools really help bring to the consultation that evidence base. And you've heard Alf talk about evidence-based medicine. So they communicate this evidence base to the patient and the clinician in an easy to understand way. And the reason that we work with the Winton Centre is because they are experts in risk communication. And a lot of what we're doing here is communicating complex risks in an easy to understand way, a simple way. All of the tools have elements of eliciting preferences, and Alf has already talked about the importance of really understanding what matters to the individual. What outcomes are they looking to achieve? What problems are they currently struggling with? Which sometimes we know clinicians find hard to do and patients find it hard to necessarily think about this within a consultation. And so this part of the decision support really enables that preference elicitation. The tools make sure that we put all of the relevant options on the table, and that's really important, including doing nothing, as you've heard Alf say, and they support people to make decisions that are right for them. So NICE have produced some standards, which you might be aware of, on the production of decision support tools, also known as patient decision aids. And one of the most important things here is that decision support tools don't advise people to choose one option over another. They are not intended to change the outcome of decisions. They're about really ensuring good quality conversations so that people can make decisions in line with their values. And if implemented in the right way, in a seamless way, they ensure that people are prepared for the conversation, which will probably feel quite different to the normal conversation that they've had, that they have time to think about their options outside of that consultation time. So it can really help things be more efficient. And we've already talked about how actually once you've got these tools in place and you've got trained clinicians, actually sometimes this can speed up time. Next slide, please. So the evidence suggests that these tools ensure that people are more knowledgeable, so patients are more knowledgeable and they feel better informed, that they are clear about their values, and they probably, as a result of using these tools, have a better understanding of their risks. And importantly, as I've just said, is that they reach decisions that are consistent with their preferences and their values. Next slide, please. So just to say, these tools are really not that easy to produce. It's quite complex. And this slide really just shows you the process that we need to go through to produce them. And that's why it's really important that someone like NHS England produces or takes the role to develop these tools, because there'd be absolutely no point in them being created in multiple different areas, because quite frankly, the evidence is universal. So this slide outlines, as I said, the process for the development of the tools, and it involves a partnership. So it's about us really working with the right people, and that includes clinicians, patient groups, charities, clinical leads, and what we call normal people. So people who are currently going through that specific decision, and we can therefore make sure that the tools really meet their needs. And as Alf has said, the topics that we have covered have been priorities for NHS England. So they're often the high volume, low complexity procedures. And the Winton Centre, as I've said before, are really the experts of risk communication. So they make sure that the tools put forward the risk information in a health literate way. And they also work with a graphics team to make sure that the tools look as good as they can. Next slide, please. So just in terms of the look of the tools, most of them look similar. I'm just going to talk through an example. This is the Dupitons tool. The tools are all PDFs at the moment, and I will show you exactly where you can find them on the NHS England website. So at the start of each tool, they're really clear about what the decision is and who the tool is for. And the idea is that the document is really a guide. So people could use it in a linear way. They could read it from front to back, or they could just dip into the section that they would find most useful. Next slide, please. And then each of the tools goes through the options. And this is the most important part of shared decision making, really ensuring that people are given all of the options. And while some of these options might not be available in all local settings, given that patients have choice about where to have procedures, it's really important they know what treatments are available. And all of these options are approved for the provision in the NHS. So as I said, always doing nothing is an option. Next slide, please. So with all the tools, this is the patient elicitation part. This is about how we really support someone. How do we have that conversation to elicit what matters to them, what's important to them? And this part of the document enables that conversation to happen and really supports it. And the person could have a look at this before the consultation as well. Next slide, please. And then we come to the important part of another important part of the decision support tools, where we put the options side by side and compare the outcomes, which is really important for people to start looking to see what the different options are and what outcomes they create. Next slide, please. And then each of the documents has the risks laid out and compared across the options, which is really an important part of that consent making process. And we know, we've heard from Alf about the litigation costs. We know that that costs the NHS millions of pounds every year, and it is often due to poor communication and documentation of risks. So the DSTs really ensure that this is done properly. Next slide, please. So here are all the topics that we have decision support tools for at the moment. The ones in italics are the ones that are currently in production, so they're not yet available, but the ones in the straight text are the ones that we currently have available. Next slide, please. And you can find them here, along with all the information, hopefully, that you need about decision support tools, so you can use the barcode there to scan and access them. And my very final slide. Brilliant, thank you. I suppose just from our perspective, really, we are confident that these tools are high quality. We're confident that there is an evidence base that they really help patients make decisions in line with their values, but it's really important that people start using them. And they're implemented across pathways of care. And if anyone's tried to make any changes in the NHS, you'll know how difficult this can be. But I think it's just really important that people know that they're available. And if you need training on shared decision making, you can access the Personalised Care Institute as well. But I will be around until the end if there's any questions or comments. Thank you, Jane.
Thank you very much, Chloe, and we will come back to you with some questions at the end if we may. And yes, the slides are going to be shared. Stella, question there in the chat. Thank you, Chloe. We're going to move on now to Rafa, who has been implementing digital consent in the southwest London region. He works at Kingston Hospital. He's going to talk to you about digital consent. So over to you, Rafa.
Thank you very much, Jane. Good afternoon, everyone. I'll go straight to the point. I know we have a very busy agenda. My name is Rafa. I've been working as project manager for Kingston Hospital to launch digital consent, originally first in Kingston Hospital and then across West London. So we're just going to talk about our experience in Kingston so far. Right, so if you can see from this slide, this is the digital consent form that we've been doing since the launch of the pilot in September 2022. We are so far nearly consented.
Rafa, we can't see your slides at the moment. We can't see your slides at the moment.
Oh. There. Sorry.
That's better. Yeah, lovely. We can see them now. Thank you.
Yeah, sorry about that. Right, so as I was saying, as you can see from the slide, since we launched in September 2022, we have nearly consented 7,000 patients digitally across 19 specialties. Kingston Hospital is planning to go paper-free by December 2023, and we're working on a business case to launch digital consent across our West London partnership. We've run a feedback for the clinicians, and as you can see here, we've received very positive feedback from the clinician perspective. So we've measured 5 measures. So if digital consent was easier, quicker, reduced time on the day, improves patient knowledge, and reduced cancellation on the day, as you can see, all the answers from the clinicians are either strongly agree or agree. And from the verbatim feedback that we received, you can see clinicians do see this process a more robust process in the Montgomery area and a smooth and very efficient process as well. On the next slide, you will see patient feedback. So we got 2 different ways of collecting feedback. We've done our own survey where we compared 50 patients that were paper consented against 50 patients that were digitally consented, and the overall digital group was happier with the system and with the digital system, and they had more access to the relevant information. Below, I also show you some feedback that we had from the digital application that we're currently using that collects feedback as well. And on some feedback, I put the age as well, because there's a misconception and the older generation is not as techie savvy or tech enabled as the younger generation, but we have a very good engagement in for Kingston's patients, with patients in their 80s and in the late 70s. So what are the benefits of digital consent? So in those slides, I put some evidence. As Professor Alf was saying, we have seen an increase of litigation cases after the Montgomery judgment. Queen Mary University research has shown that this is there are 4 times more consent-related cases by March 2020 compared to the previous 4 years. And so this is amounting at 62 million per year at the moment, an increase of 34 million. And as the public becomes more aware of the shared decision making and their consent process, this number will increase, which is the same thing that the Royal College of Surgeons is saying. And the way digital consent tackles this is by providing an accurate system, so with an accurate records, and it will provide the patients with procedures information, the risks, the benefits, and alternatives, and even the options of doing nothing, as Professor Alf was saying earlier. So also correlating to what Professor Alf was saying, consent is a stage or a process which is overall, it can influence the shared decision making, and we've seen that in some of the research done here in the UK. Like, for example, when digital consent was used, we had an increase from 88% to 72% of patients reporting gold standard shared decision making. And also another research that is showing that digital consent increased the patient's perception of their own involvement into the process. And I want to go back to my previous slide to show you this from actually a patient's feedback that says the consent process makes the patient understand better as to what lies ahead. It enables to put patient's mind at peace, and it provides informed decision making. I think this feedback just explains it all, the benefits of using digital consent. There are a few more benefits involved into this process. So, for example, Imperial College has analyzed a reduced cancellation by 5-10%. Also, increasing clinical and admin time. Being digitally, obviously, there is a cut into the carbon impact because we don't use paper, but it's just a net zero cloud hosting system. And the application that we're using at Kingston is also compliant with the work that NHS London has done to design 59 standardized consent forms. So all those forms have been incorporated in our digital consent platforms. Those are some references for you. Those slides will be shared, as Jen said previously, so feel free to have a look. Any questions?
Thank you very much, Rafa. That was unfortunately, we didn't give you very much time, so that was a rapid race through that. And I see Kiara's put in the chat that she loves Concentric, which is the platform that you're using in central London. And I would certainly encourage all of you to have a look at a digital consent platform because it really does cover all the bases. I have a question for you about hubs specifically, Rafa, and I know this is something we've discussed. So if you are working in a small-ish, compared to a trust, discrete hub, is digital consent something which it's possible to implement just within a hub site?
Yeah, absolutely. It can be implemented in whatever trusts in base, regardless of the size of the hub. So it's absolutely possible.
Fantastic, thank you. And Elizabeth down in Devon is asking, does Concentric integrate with EPRs like Epic?
So I can't say for sure because we use Cerner Oracle here at Kingston, so it does integrate with Cerner, but I can't speak for the Epic system because based on my experience, I don't know.
Okay, thank you. So I think that would have to be a question for Concentric, Elizabeth. But I do believe that Epic is integrating with it in some sites where they're already using digital consent. Okay, brilliant. Well done, keeping to time. Thank you very much, Rafa. Are you going to stick around for any more questions at the end?
Yeah, I can do.
Perfect. Thank you very much. Okay, we will move on to the next item on our agenda. So next we have Angarad and Pete, who are online from the Royal Orthopaedic Hospital up in Birmingham. We wanted to give them and you the opportunity to hear about a shared decision-making journey, because shared decision-making isn't fully implemented everywhere, as I'm sure you're all realising through this call today. So they are on the journey and they're going to talk about where they are and what they've been doing. So thank you.
Hello, my name's Angara McGregor and I'm presenting with Pete today. Can I just check the slide has moved on to my table?
Yeah, we can see that.
Yeah, cool, lovely, thank you. So we, Pete and I are in our shared decision-making group in the trust, and this is a table that we talk about each meeting, and it's using the CUSA approach. So this is the driver diagram of how we're trying to get through and implement shared decision making in the trust. We've got 5 main objectives about increasing knowledge within staff, reviewing our patient information, increasing knowledge within our patients, measuring shared decision making, and then supporting the consent process. We are at various stages of success along the journey. One of the things that we are planning to do by the end of the year is to hold our first in-depth training workshop with our consultants. And this is a piece of training that the ICS designed, and we've sent 2 members of staff on, and they have received the how to deliver the training. And it's quite an interactive, so role-playing, challenging back, thinking how people can say things differently. And the evidence does support that that's better to train people rather than sort of just passive reading something. We're going to couple that with some brief raising awareness sessions. We've got a presentation happening at the end of this month within our consultant meeting. Pete's going to come on to educating our patients, but we've also done some improvements on our website to just standardize our patient information, trying to follow the Brown approach. And we're about to launch a wholesale revision where we go through each specialty in turn and go through their patient information In terms of evaluation, then we managed to put the Collaborate into the outpatient questionnaire, and the Collaborate is 3 items of how much effort was made, and the results are pretty good. So from a QSER perspective, like trying to measure improvement in quality, as long as we sort of stay high, that's good. April and May, I'm pretty sure the data isn't accurate. I think when it was first implemented, the Likert scales were translated the wrong way, and then someone who translated the right way, but we didn't record the date, and so we can't work out when that happened. So the data is there, but I'm not confident in it. Pete, over to you.
Hi, so I'm going to take you through a bit about the patient campaign that we're kind of on the journey creating. The plan is to create a campaign that reaches patients across their entire journey. So we're going to help them to understand that it's okay to ask questions. We've based the campaign around the Ask Through questions. We did that because we felt that if with the BRAN acronym, if you're nervous in a consultation, you're not necessarily going to remember that. But with the Ask Through questions, even if you forget what the questions are, you're still going to remember, oh, it's okay for me to ask questions. The campaign that we created starts off with the patient letters. So when a patient receives a letter, they have their normal letter on the front, and then on the back, got a nice little map to show where to go. But then underneath, you've got the recommended questions, and it talks about what shared decision making is. And then on there as well, there's a QR code. And when you scan that QR code, it takes you to a video that we're just in the middle of making at the minute. And that video kind of demonstrates what a good quality shared decision making conversation looks like for patients. And it's coupled with a voiceover as well as a patient talking to a consultant. That website, that video is housed on our website. And as Aunt Harrod said, we're going through a process of changing all our patient information, but as well, when you're with that video, you're going to get more prompts about asking questions and the kind of shared decision making process. Alongside the websites, we're creating some posters as well, so a campaign there. The poster that you can see on the slides is just a quick mock-up to give you an idea of what we're looking at. It's not necessarily the final one yet. But those posters are going to be around the hospital, and they're also going to be in the consultation rooms. So the patients are getting this kind of journey of from letters to videos to posters. They're going to be able to see and be reminded that it's okay to ask questions. When they're in their consultations as well, we're going to be able to give them some leaflets, which they'll probably be able to pick up from the waiting room, that have the questions on it as well. So with spaces underneath to be able to write the answers. So it's a kind of a prompt to be able to take that decision forward and help guide those conversations as well. And as I say, we're kind of going through the process of producing all this content. So once we're at the point of we've got some collateral, we're then going to bring together a patient focus group, and then we'll be able to really refine the language that we're using, making sure we're getting it right for the patients as well. So that's kind of a whistle-top tour of our campaign that we're doing for patients.
Thank you both very much. We've got a couple of questions here for you, and then we'll come back to Rafa and Chloe with some other questions. So Pete and Anchor, while we've got you, there was a question about slide 3. Is the 0 to 100% or values on slide 3? That was from Deary James.
It's a percentage.
It's a percentage. Hopefully that answers the question for you, Deary. And also training for staff. Will you be training staff in how to do this, or will you just let them know what's happening?
So in-depth training will be delivered to consultants over time, and anyone who does take consent, and the briefings will happen to staff once we kind of launch. We want to launch it all together rather than in stages.
Perfect. That's great. Thank you very much. So let's go to some other questions then. Chloe, I see you've been answering lots of questions in the chat. One of the questions up there, you did answer about the decision support tools being translated into different languages. What about easy read or large print versions? Are there any plans to have those?
We've been trying to create some easy read versions from our Winton Centre's tools, but I can't confirm whether or not they will be available. I could take that away and come back, Jane, if we answer any questions afterwards, and then I can be really clear about which ones will be an easy read and which ones won't.
I think that would be really helpful. Thank you, Chloe, if you can let us know, and we'll make sure that people are made aware. A couple of questions for Rafa. So on the digital consent form, first of all, how well is this received by patients? You've done some testing with patients, but how does the process actually work? Does the patient look at it on their own at home, or do they go through it with the consultant? So that question came in from Steph in Derby and Burton Hospital.
Right. Yes. Hi, Steph. So we've been implementing this tool from the clinics. So basically, the consultant, as he goes through with the patients planning their procedures, he goes through the application and he shares all of that information with the patient. So the patient is able to go home, receive that information through their email or phone number, and then they can have easily access to all the information that is there, and then they can discuss with them. They can involve their families. They can have, they got appropriate time to make an informed decision. And then if they want to have, another thought, they can also contact us back and say, and plan something else if that is the case.
That's great. Thank you very much. And do patients manage this okay when they're looking at these on their own?
Yeah, I mean, as I said, the feedback that I shared with you, we have patients in their 80s and in their 70s. I mean, it's very easy because all they do is just they either receive a text or a link, and then with their phone or their tablets. I mean, I have to say, well, it's probably in Kingston we have a very tech-savvy generation compared to the rest of the country. I'm not sure, but we have receiving a very good feedback, so it's quite easy for them to access it.
Fantastic. Thank you very much, Rafa. We've got another question here about shared decision-making tools. Chloe, will the decision-making tools only apply to procedures? So that's come from Susan Douglas. Susan, I don't know if you want to elaborate on that question a little bit. Do you want to put your camera on? Ah, there she is.
Hi, so thank you. It's really that question of, so does it apply to medical conditions? So, and I think you did put up one about heart failure, but it's will we have other conditions? Because we've been doing lots of shared decision making in our trust, and we recognise, I don't want it to seem as if it's something just for the surgeons, because I think it is for the physicians as well. It is about involving people in decisions about their care. So not just about procedures, but medication, etc. So yeah.
Yeah, absolutely. That's such a good point, Susan. I think the reason that we chose those ones in the beginning, as Alpha said and I alluded to, they were the high volume, low complexity procedures. And obviously after COVID, we had very huge waits. So they were the kind of tools that were prioritised. But you're absolutely right. There could be so many different things where we could have decision support tools. And some of those things, there wouldn't even be a particular medical intervention that might happen in secondary care. So I think you're absolutely right. I think, unfortunately, we don't have a kind of endless budget for this work. So we do have to prioritise. And when we prioritise them, we obviously have to have really good engagement from specific clinicians as well, and from patient groups. So believe it or not, there's quite a lot that goes into deciding which tools we're going to create decision support tools for. And even when we think actually there'd be really good, this one would be a really good topic to do it on, if we don't have the clinical engagement, we can't necessarily drive that forward. So I hope that answers your question. As Alf said, there's 30 coming. My hope is that there'll be more, but there are obviously costs attached to the production.
Thank you.
Thank you, Chloe. Got another question here for you in two parts, really, and then we'll come back to Rafa with another question about digital consent. So are there any plans to communicate the SDM tools with primary care? And then someone else has asked, should patients have seen these first at the GP practice?
So absolutely. So almost those questions kind of come together, don't they? So, you know, and Alpha said, you know, ideally, we want to be using these tools and starting that decision-making process as early as we can upstream. So absolutely, we want to make sure that primary care know that these tools are available, and there's different ways that is happening. We have personalised care regional teams, we have personalised care leads in each of our 42 systems who are making sure that people know that these tools are there. But knowing that they're there and implementing them in practice, there's quite a jump, isn't there, to knowing that they're there and implementing them in practice, especially for GPs who often only have 10 minutes for a consultation as well. In the MSK space, we know that our first contact practitioner physiotherapy therapists who might have a little bit longer are starting to use them in primary care. And we're certainly seeing them being used more in community MSK services as well, where we've got those interface services. And to support this, we have started to write two-stage decision-making and consent into GIRFT pathway guidance, which clearly shows that stage 1 conversation happens within primary and community care, and stage 2 happens within secondary care. So I hope that I have in part answered that question. It's really important these conversations start as early as possible. That creates value for the individual, but it also creates value for the system as well.
That's great. Good answer. Thank you, Chloe. Thank you. Going back to Rafa. If patients receive the decision-making tool after they've seen the consultant surgeon in clinic, when and how do they inform the trust of what their decision is? So I think people are thinking, if they're looking at this consent form digitally, how do they let the trust know what they've decided?
So patients can have, they can decide to sign for those consent if they wish to go ahead, or they can just decide not to sign those consent forms and put a comment on the applications that we're using, and they can contact the hospitals if it needs to change before the procedure goes ahead.
So are you saying then that if they had another appointment, they look at the consent form and decide that, having looked at shared decision making, they don't want to go ahead, they can just contact the hospital, or they just don't sign the form, basically?
Yeah, I mean, they can do both. Don't contact the hospital and don't sign the form. And if they agree, they can sign the form, which it doesn't mean that on the day, that's the whole point. Shared decision making is an ongoing process. So even if you sign the consent form, doesn't mean that's it. That's the end of the process. If we're just going to carry on and do whatever, patient can, always change their mind up to any point before their procedures, and then there's this time for them to ask questions another day as well.
Brilliant. Thank you very much, Rafa. Okay, that brings us to the end of the questions, and very timely end to the masterclass. Thank you all so much for participating today. Thank you to all our speakers. Thank you to all of you for joining. The next masterclass, as Helen's just dropped into the chat, is on the 22nd of November. That is around finance and funding flows, and we're going to explore some of those areas for hubs in particular. So do please make your finance colleagues aware of this, but it will be relevant for clinical and operational colleagues as well. The documentation from today will be added to futures, as we've said, so that you'll be able to see all of those. And the only thing that remains is to ask you all to turn on your camera and say hello to all the speakers, because they've been sitting looking at a blank screen for most of the session. So if you could just turn on your cameras and say hello, that would be lovely in traditional masterclass style. So thank you all very much.
Bye.
Bye.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Thank you. Bye.